This is a study of AML patients with FLT3-ITD mutations. These mutations are perhaps among the most common found in AML and confer a poor prognosis. Such patients typically go, when feasible, to an allogeneic transplant, and it is common to offer the patient a FLT3 inhibitor as maintenance therapy post-transplant. This question is not resolved as to whether it should be done or it should be done in all patients. And so this trial was designed to first ask the question, should it be done for everyone? And if not, can we use measurable residual disease to identify those who perhaps should get the drug? Measurable residual disease is one of the most common or reliable prognostic factors in AML. It refers to very low amounts of disease, so 1 cell in a million. So a patient's in remission, but still has the disease at a low level that could regrow, whereas some are obviously cured by the transplant itself. So how to distinguish the two? We hope to use MRD. The trial was a randomized double-blind placebo-controlled trial of Gilteritinib versus placebo, so simply asking the question, will Gilteritinib, a FLT3 inhibitor, help everyone? Worldwide, 16 countries, 110 centers, with a primary endpoint of relapse-free survival, and these secondary endpoints mostly really focusing on MRD on those endpoints. And here, walking through the flow, patients had to be in remission and designated for transplant with a FLT3-ITD mutation. They registered. We collected a sample of bone marrow aspirate to assay for MRD at this very sensitive level. We didn't require any type of transplant. It's worldwide. However, one does this, which is many different ways. Immediately after the transplant, once they're engrafted, and before they start the maintenance therapy, collect another sample for MRD. So that's the peri-transplant MRD. They are then randomized to Gilteritinib or placebo, double-blinded, and followed for 24 months, and again, with these stratification factors. The primary result of RFS, we did not meet. Not everyone benefited from the drug, perhaps not surprisingly. We actually came very close, 0.0518, and in fact, you can see a benefit from the drug in general there on the right, but it didn't meet the pre-specified level of significance of 0.05. However, when you break it apart by those who have MRD, you see your answer. And the curves clearly separate into two groups. Fully 50% of the patients have MRD, and as we can see, benefit from the drug, and the others don't. So to some degree, a negative trial was quite a success. We specifically identified the patients that need the drug. In addition, we have a great deal of data on toxicity, on pharmacokinetics, et cetera, to learn more about this patient population. Here is one little tidbit of data from the MRD studies. So we're looking at two patients, one on placebo and one on Gilteritinib. Remember, no one knows what's happening. Everybody's blinded. They're blinded to the MRD. They're blinded to the drug. But in retrospect, you can go back, and as shown here, this patient on placebo, transplant is occurring here. Before the transplant, there are two clones, a 48 base pair and a 63 base pair. After the transplant, the red, the 48 base pair clone is still detectable at a low level, is rising by 6 months, and the patient relapses at 9 months. So this is an illustration of using this assay to detect who's going to be at risk of relapse and can intervention be done. Whereas over here, the patient on Gilteritinib, the clone is detected pre-transplant, drops a little bit, but is still detectable after the transplant. The Gilteritinib is started, and the clone is eradicated. So again, perhaps an illustration of the utility of this drug in intervening when we detect MRD. So the data are among the first to prospectively demonstrate a correlation between MRD and relapse-free survival and overall survival in post-transplant maintenance therapy for FLT3 mutated AML. It does appear to have a clear benefit for the 50% of patients with detectable MRD pre or post-transplant compared to those without. It should be a standard of care for patients who are MRD positive in the pre or post-transplant setting. For MRD negative patients, clearly of less benefit. And in addition, there were regional differences that we saw, which we're going to explore in the methods of transplant and impact of the drug. but gilteritinib improved MRD eradication in patients with detectable MRD pre or post-transplant compared to placebo.